In this video, we'll discuss about Mycobacterium leprae. First, morphology. It is a gram-positive bacillus. They are acid-fast but very less than tubercle bacillus. They can occur singly or pair, single or group. They can both intracellular and extracellular. They can occur single or group. They can be intracellular or extracellular. The bacilli are bound together by lipid-like substances. That lipid-like substances name is called as clia. This is clia. And the entire mass are called as globi. So it can occur singly or grouply. They can both extracellular and intracellular. Bacilli bound together by lipid-like substances name is called clia. So the entire mass name is called as globi. They are arranged in cigar bundle appearance. How they arranged? Cigar bundle appearance. They appear in Virchow lepra cell or foamy cell, which are large, undifferentiated. So this one is large and undifferentiated in histosines. They arranged cigar bundle appearance. They appear Virchow lepra cell or foamy cells. Now discuss about leprosy. It also called as Hansen disease. It is a chronic granulomatous disease. Leprosy is chronic granulomatous disease of human. It predominantly involved in skin, peripheral nerves, nasal mucosa. So this one predominantly involved in skin, peripheral nerves and nasal mucosa. Classification, it also called as Hansen disease. It is Ridley and Jopling classification. We knows two form of leprosy: tuberculoid leprosy and lepromatous leprosy. This tuberculoid leprosy, it is represent highly resistant. This one low resistant. It caused by bacterium Mycobacterium leprae. Between this tuberculoid leprosy and lepromatous leprosy, between two there is middle one, borderline leprosy. Between lepromatous and tuberculoid leprosy, middle we have borderline. This one is the dimorphous. One more PT, one more BL. PT borderline tuberculoid, another one is BL borderline lepromatous. So totally tuberculoid leprosy, borderline tuberculoid, middle borderline, borderline lepromatous and lepromatous leprosy. This tuberculoid leprosy in skin, it is presented in skin. This one mainly presented in face. Tuberculoid leprosy in skin, few lesion, asymmetric, hypopigmented, erythromatous, macule, and they are sensory impairment. Sensory impairment. In lepromatous leprosy, symmetrical, multiple nodules, macules, pacules, diffuse, multiple symmetrical lesion are there. It will give a lion face. Okay, that face look like lion. Not sensory impairment. Here we can feel sensory. Here this one here we not feel, but here we can feel. Tuberculoid leprosy, if you pick not having sensation. Tuberculoid leprosy, if we pick we don't have any sensation. Then leprosy test positive. Leprosy test positive. He has resistant fight against. He have good immune response. This person having good immune response. That's why it is calling highly resistant. This one, lepromatous leprosy, leprosy test negative, not good thing. It is suppress and low resistant. Histopathological studies of two types of leprosy. This one is the lepromatous leprosy. Here we can find out clear zone. This zone name is called as grand zone. Then here we can find out macrophages, then foam cells, that is lepra cells, and clear zone. In tuberculoid leprosy we can find out eroded epidermis and that kind cell also we can see. In summary, tuberculoid leprosy body has immune response. Then lepromatous leprosy, this one low resistant, body not have immune response. Next, discuss about two major type of leprosy. Difference between two type of leprosy, lepromatous and tuberculoid leprosy. Lepromatous leprosy, the host resistant is low. The bacilli are found in large numbers, so it is referred to as multi-bacillary disease. Tuberculoid leprosy, the lepromatous leprosy, high degree of resistance. The bacilli are very scanty and referred to as paucibacillary disease. So this one referred to as paucibacillary disease. This one is scanty. Here large number of bacilli is presented, so multi-bacillary disease. Lepromatous leprosy, the superficial nodular lesion, that is called lepromata, are seen. Superficial nodular lesion, lepromata are seen, which leads to ulceration of nodules. This one progresses to secondary infection which occur distortion and mutilation. So ulceration of nodules leads to secondary infection, then which causes distortion and mutilation. In tuberculoid leprosy, the skin lesions are few and they are sharply demarcated and consists of macular anesthetic patches. The lepromatous leprosy stage is more infection than tuberculoid leprosy, which has minimal infectivity. Lepromatous leprosy more infection and comparing to tuberculoid leprosy. This one is the minimal infectivity. Then this lepromatous leprosy has poor prognosis. They deficient cell-mediated immunity. Aggregated humoral immune response which leads to production of more autoantibodies. But this one tuberculoid leprosy, good prognosis. There is adequate cell mediated immunity, so the autoantibodies are rare only, but here more autoantibodies. Then leprosy test negative. Lepromatous leprosy, leprosy test is negative. Here it is positive. Tuberculoid leprosy, leprosy test is positive. These are the main difference between tuberculoid and lepromatous leprosy. Next, genetic predisposition. The HLA-DR2 is seen predominantly in person with a tuberculoid type of reaction. Then HLA-MIT and HLA-DQ1 are seen in person with lepromatous disease. The infection with lepra bacilli stimulate the humoral and cellular immune response. If deficient, cell-mediated immunity. Lepromatous leprosy develop delayed hypersensitivity to lepra bacillus protein is absent. The predominant lymphocytes are seen here at CD8 plus cell, and the leprosy there is reversal of albumin globulin ratio. Let's discuss about that lepra reaction. There are two major types of lepra reaction, type 1 and type 2. Type 1 is also called as reversal reaction or lepra reaction. It is also called as reversal reaction or lepra reaction. This is most commonly seen in borderline leprosy. The lesions here are erythema, swelling with pain and tenderness. The biopsy there is shift to lepromatous pattern. Second, type 2, it is called as erythema nodosum leprosum. Erythema nodosum leprosum. This is common with lepromatous leprosy and borderline leprosy type. They are graph of tender inflamed subcutaneous nodules with the presence of fever, lymphadenopathy and arthalgia. Characteristics: neutrophil infiltration, immunoglobulin G, complement deposition in lesion. Let's see about leprosy test. This one is the standard leprosy from leprosy A or injected two type of reaction. Early reaction of Fernandez, late reaction of Mitsuda. Early reaction of Fernandez. It consists of erythema and induration developing in 24 to 48 hours and it remains for 3 to 5 days. That is similar to tuberculin reaction. In late reaction started in 1 to 2 weeks, it reach in 4 weeks and gradually subsides in next few weeks. This consists of indurated skin nodules which may ulcerated. In healthy person, in non-endemic area with no chance of contact with bacillus are positive to leprosy test. Applied importance of leprosy test. this is used to classify lesion. It is positive in tuberculoid, negative in lepromatous leprosy. Positive reaction indicate good prognosis. Then to assess prognosis and response to treatment. Third one is to assist to assess the resistance and to verify the identity of candidate lepra bacilli. So importance of lepromine test: classify lesion, to assess prognosis and response to treatment, to assess resistant. Laboratory diagnosis: it is easy in lepromatous leprosy but difficult in tuberculoid leprosy. The specimen collected are nasal smear, skin smear, then no biopsy. Microscopy demonstration of acid-fast bacilli in lesion, and grading is done based on number of bacilli to see the severity of the disease. Stain used: Zell-Nelson staining using 5% of H2SO4. Zell-Nelson staining. Then culture. Mouse foot pad inoculation and armadillo inoculation method. Serological: here detection of antibody against Mycobacterium leprae. So detection of antibody. Specimen: nasal smear, skin smear, and now biopsy. Microscopy demonstration of acid-fast bacilli. Then staining: Zell-Nelson staining by using 5% H2SO4. Culture: mouse foot pad inoculation, armadillo inoculation method. Serological technique: antibody detection. Then treatment: Tap zone. First effective drugs, but nowadays resistant. So nowadays recommended multi-drug therapy in leprosy. Palsy leprosy lesion means rifampicin 600 mg once a month given. Then Tabzone 100 mg for daily up to 6 months. It will follow up 4 years minimum. Then multiple bacillary lesion, rifampicin 600 mg once a month. Then Tabzone 100 mg daily for 2 years, added with tofazimine 50 mg for daily up to 2 years. Minimum follow up 8 years. So this is all about leprosy. Mycobacterium leprae morphology. Classification: tuberculoid, lepromatous, middle, borderline. Then PTPL, borderline tuberculoid, borderline lepromatous. Histopathological diagram. Foam cell, here giant cell. Tuberculoid leprosy body has immune response. Lepromatous low resistance. This one different between lepromatous and tuberculoid leprosy. Lepromatous more infective one. Tuberculoid, minimum infectivity. Lepramine, that lepra reaction, two types. Laboratory diagnosis, treatment. Paucibacillary lesion, multibacillary lesion. Thanks for watching.